Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, facial trauma. And I wanted to get a true expert to discuss this topic, so we have Bilal Joseph. And he is a trauma surgeon. He is an endowed professor. I'll talk about all his accolades in just a bit. But he put out an amazing paper in the Journal of Trauma establishing facial injury guidelines. Now, if that FIG sounds familiar in the world of trauma, it's because they have already put out the brain injury guidelines. And we'll surely have him back on another show to discuss those because those are game changing. But he has put together a list of transfer criteria. And, you could check out the study for all the background, the multidisciplinary expert panel they assembled, the literature search, everything. It's a fantastic paper. I mentioned it on the Rack Lit review for last month, which is only available to members. So if you're like, what's that? It's because you're not a member and you should be. You should join. If you already are a member, of course, then thank you. But I figured it deserved its own episode because facial trauma is one of those areas where like, what do I do here? Is this a big deal? Is this nothing? Do I send them home? Do they have to get admitted? Do they have to get transferred? So I thought this would be a great topic. So let's just have a brief diversion and then roll right in. So we always start with the first question. Who are you and what? Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning. And then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Hey folks, real quick, a mention of our upcoming course, Unburnable. You might have also heard me call this Flameproof. We've changed the name. It's now Unburnable. And we are having our fourth cohort. I can't believe we've done it this many times. Fourth cohort starting September 16th, 2025. And if you've heard me talk about this, you already know what it is, but really quick if you haven't. This is our virtual course that I host with my coaching partner, Rob Orman, on career longevity, anti-burnout, and self-mastery. Essentially, you will become unburnable at work. It will flow into your home time. You will be far more sanguine. You will like life more. You will start kicking ass. You will start wanting to come into your shifts rather than dreading it. Sunday nights will no longer be a disaster if you're working on Monday. It is 12 sessions, 2 hours each. We do every 2 weeks. So you're going to have us for 6 months percolating through your mind with topics like silencing your inner voice, your inner critic, agency and perfectionism, effective communication, shift overwhelm and efficiency, mindfulness and meditation, on-shift strategies to find joy, the fundamentals, things like sleep, life management and productivity, burnout prophylaxis, and then putting all of that together into a new system, a new strategy for enjoying work and life again. Everyone who has taken the course has given us positive feedback. For some people, it has been truly career-changing. And I think you at least owe it to yourself to check it out. If you are currently in the throes of the beginning or mid-stages of burnout, then you should take this course. If you never want to get to any stages of burnout, you should consider taking this course. So just come to Unburnable Course. That's one word. Unburnable course, because it's a course.com. Unburnablecourse.com. Check it out. Look at the topics, look at the dates, see if this works for you. They're all recorded, so if you have to miss some of them, it's not a problem at all. You'll be able to watch the videos of your actual cohort and then still deal with all of the issues raised. There is a community that goes along with it. It's just friggin' fantastic. So if this interests you, come to unburnablecourse.com. All right, let's get to the show. You do.
Hi, who am I? Wow, that's a tough one. That's a no.
Not on an existential level, just
No,
probably on
I'm
a
Bilal
clinical level.
Joseph. I'm a trauma surgeon in Tucson, Arizona. I do trauma, emergency surgery, critical care, and I believe to be a catalyst for change. That's the best way to say it.
Yeah, yeah. And you won't spout all your accolades, but you've won awards. You're the director of trauma. You're the chief of surgery. You're an endowed professor. You're all sorts of great shit. And you wrote as senior author a amazing paper. I think the paper that has the best title of the year easily. Look me in the face and tell me that I need to be transferred. That is amazing.
We spend a lot of time on the titles. You'd be surprised. It's like the menu item that gets people to read the paper. I've learned that this is probably my one of my top three. I have a couple other that resonate, but absolutely.
Loved it. And it delivered, because I think we'll see if something supersedes it, but it is my favorite paper of the year because it delivers not just on the research side, there's incredible facts and incidences that I think are really important, but it delivers in the area that I think must have increased prominence, which is clinical utility. Someone could take this paper and change their clinical practice, especially if they're in an outlying hospital. You don't want to accept these transfers if they're unnecessary. They don't want to make the phone call. That's 20 minutes out of their life just to hear, no, we don't want it. So it helps both sides. Tell us a little bit about the nidus of this paper.
Yeah, I will just tell you, we started probably in 2012 with BIG, which is the brain injury guideline, which now has become a standard of care after 10 years. And it's got its different names, but at the end of the day, it's all the same concept. And so this is actually FIG, and that's the face injury guidelines. And the whole concept really, as you said, Scott, like at the end of the day, what we do at the bedside impacts our way of thinking. And the number of times I've had to watch a family member, I feel like this is the blind spot in what we do. But in Arizona, a helicopter flight is $30,000. We're the only level 1 ACS in the Southeast. And I'll tell you, like, watching families have to come pick their loved ones up, or having someone transferred in, be there for 4 hours and leave. Our ED colleagues, our trauma colleagues, this becomes overwhelming. And then at the end of the day, it's our patients. And so that's really the motivation. And face fractures is one of those areas, like you just say face, and it's everybody just, oh my God, face. And so we've been thinking about it for a long time. And that's really how we got here, to understand what this really is. We really need to be focused on this for our patients, for our healthcare systems, and also for our own wellness. We on average see about we're like you guys, 20, 25 hits a night. If you can reduce that by 3 or 5 patients, your residents, your faculty, your fellows everyone, can feel that impact. So.
No doubt. So before we get into the actual transfer guidelines, who are you getting facial CTs on? Are you just doing it empirically on some patients? Are you just waiting to see the results of the initial head scan and deciding on that? What is your paradigm?
Yeah. Anyone with external signs of trauma, number one, in the face area, automatically. A pan scan has become almost standard in a lot of our centers. And the other one, I do think physical exam still has a play. If you push on someone's face and they have pain, that's another one. So so anyone with a non-examinable, anyone with high mechanism facial trauma, anyone with external signs of trauma, and anyone with a physical exam that elicits pain, because you're not going to get plain films, and taking the patient, bringing him back, and then trying to get another line in CT is pretty hard. So we are very aggressive in that realm of those, I'd say those 4 realms.
That's funny. We have 2 standard order sets. We have like our trauma activation, but they're not crazy sick. And then we have our high level trauma. And the high level trauma is just there to get the facial cuts. It's just not worth it in those patients. They got more shit going on than they need a second trip to CT. Is that the same for you guys?
Pretty much.
Yeah.
We're
right.
Same. Cool. Yeah.
Who are you getting temporal cuts on?
Anyone who has a temporal bone fracture gets the temporal cuts. That's really the only, if the initial CT reads any type of temporal bone fracture, they will get a temporal bone scan.
All right. So that's done sometime down the line. That's not an emergent scan.
Correct. Usually to be honest with you, our ENT colleagues, our face surgeon colleagues would always want that. And so now we've standardized it. If you do have a injury in that area, then that's who we would go on to go ahead and get a temporal bone cut on.
I love it. All right. Now, before we get into the individual injuries in the FIG, a lot of these, it makes absolute sense to not have to transfer them to the big center. But for some of these rural places, and I don't know if it's like this in southern Arizona, but it's not even a problem of do we need them to send them to the big center that night. It's that we have no doctors who are really appropriate for follow-up for these patients in some of these centers. They might have an ENT, but this ENT is not the one you want taking care of facial trauma. Do you guys ever accept calls and just have some way of booking them into your facial trauma service for outpatient follow-up?
Yeah, that was one of the things we tried to do early on because, of course, we're 50 miles from the border. I don't want to get into the inequities of healthcare in America, but the truth is and there's a lot of uninsured people in our region. If there are subspecialists realize also that the burden of healthcare on the system is great through the emergency room. And so they can have a clinic visit. And remember, a lot of these phone calls that come from 50, 70, 100, 200 miles away, but they're not going to do anything in ED. So most of them will either have a phone call, have one clinic follow-up. We've set that up with them where they'll actually see them one time through a phone call, through a discussion. And that's how we've done that.
All right, that makes sense. And is there any leeway on this for patients who you just think will never follow up if you sent them home?
Yeah, I think when you look at the study, the fact that 50% left with nothing ever needed and discharged within 6 hours, that's a huge population. And and then the ones who did stay, 89% had some sort of procedure. I know we're going to get in the paper, but I think this is an important point. 89% had some sort of procedure once they were admitted. So I feel like the ones that you're not going to transfer are never going to need anything. And most of our colleagues at level 3, level 4 centers can manage pain. PCPs, they need to make a comeback into this whole world. But the patient who's not going to follow up, we deal with that quite a bit. And I would just say that they heal and do well. And that's the truth. We just don't. And it's funny, initially when people are like, oh, they're not following up. How are we not the program? There was a 20% follow up in that set of papers early on. So this is a common thing in trauma patients, but people got to live their lives. And honestly, the financial impact of medicine has impacted people so much that people don't want to waste money just to feel good. I think that's another piece.
All right, let's go injury by injury here. So we'll start with the upper facial bone fractures. So frontal sinus basically all get transferred, right? Tell me a little bit about that if you have anything to say.
Yeah, I would just say for the upper, there's a lot of CSF leaks in these. We've realized that this is a high impact mechanism. This is where you're going to get two services that are going to need to make a decision. So I would say those are the ones that even if they don't need surgery to fix the face, the CSF leak is a real concern in this arena, and you need to be focused on that. And so that's why, without question, I think these are the ones. And over time, we could maybe figure it out if it's displaced a certain amount, but right now at the high level, that's what we're thinking. Yep.
Makes that easy. All right, we'll go to middle facial bone fractures. Now, when I was at Shock Trauma, Shan McGanathan was there. Did you have Shan?
Yeah, Dr. Shan, the Shan scan.
Yep, the Shan scan, which I think was the progenitor of the Pan scan. So Shan told me if there's no opacification of the maxillary sinuses, then there's no mid-face fracture except the nasal bone that you have to worry about. Have you found that to be true? I haven't found a case that belied that.
I would just say I never disagree with Dr. Shan. I did a month of radiology. I did a month as a fellow, and I do remember something along those lines, to be honest. But I think he's right.
All right. Now, if anyone has an opinion about this, put it in the comments. If you've found a study, if you've had cases where they've had actual mid-face fractures and no opacification of the maxillary sinuses, tell me. I'm super curious. And if no one can find anything, someone should do this study. This is an easy resident project. You could just retrospectively find all of your facial fractures and then go in and look at the maxillary sinuses, see no blood there with a fracture. Well, we've lost, but I'm curious. Let me know what you think. All right, let's talk orbital fractures, probably the most common mid-face fracture. So you guys have transfer if there's decreased visual acuity, diplopia, restricted ocular motility, or retrobulbar hemorrhage, or a comminuted fracture, because that really speaks to a high mechanism injury. Tell me a little bit about this.
Yeah, what I would say about this is really what's important is the physical exam is really still real. Like the fact that you have something that the patient is complaining about beyond, we're not treating a scan, we're treating the patient. So it is data from the scan plus data from the patient. I think this is one of the, I think orbitals how many orbitals we get also. That's the other thing. what we didn't do in this, like we did in big, is we quantified this like objectively. Do you know how many lateral orbital wall fractures we get that are like you can't even see, right?
Absolutely.
It's like 3 millimeters and you
Yep.
can't even draw 3 millimeters, and you're like, what is going on right now? And I think that, but I do think the minute you get into what we talked about here, the vision, the diplopia, the motility, now you know that there's compression, there's quite a significance, and I think that's where the exam is critical, and you spend a little time on those patients.
Now, you have retrobulbar hemorrhage here. When on the phone are you and your brethren saying, look, guys, you got to suck it up and actually make the cuts at your place? They're not going to make it 50 miles.
Yeah. The problem we struggle with, look, at the end of the day, we always try to walk through and talk through. I've done a lot of work in telemedicine as well. What you realize right now in healthcare, a couple things, like some of our EDs are like 1 or 2 beds, maybe a CT scan. And then they have these docs who come in 2 or 3 weeks and they're gone. It's very different than, I have friends in Virginia. They talk about, oh, this physician, his father was the physician, his grandfather was the physician, his great grand, and then they're engaged. And I think it matters who you're talking to, because if you get someone who just doesn't want to deal with it, you can never force people. And that whole idea of transfer etiquette has become a real thing.
Anything else on orbital fractures before we move on?
No, they're not all created equal. That's all I was saying. You got to put the physical exam with those. I think that's important.
All right, let's talk about the real, not as critical ones, the zygomatic arch, nasal bone, and maxillary sinus fractures. Now, for almost all of these, there's really no reason to transfer any of these patients, correct? Is there any patient you'd have transferred?
One of the exclusion criteria in this was cosmetic. And sometimes young kids, maybe there's a cosmetic reason from a career or something. But it's funny, if we were waiting for consults in our own trauma bay for a while for these before we even get out of the hospital, and they'd be like, why are you consulting us on this? They're fine. They don't even need to follow up. They're good. I don't think that that red line of do not transfer, I think I'm comfortable with all of these saying there's really no reason. You did a podcast in 2012 or 13 on, is it hemorrhage in the face? Or
Mid-face hemorrhage. Yeah, absolutely.
Yeah, face. And so I think that's where you got to be smart about it. You got to make sure that you don't have that. But if it's just a straight T read on a patient, they're going to have swelling. They're not going to be comfortable. There's going to be some pain, but that's about the line.
And you do make a point to say, look for the septal hematoma. And if they have it, that's clearly drainable in the ED. And then they could follow up.
Yeah.
All right, let's talk about the more complex fractures, the zygomatic maxillary fractures. And those, it goes back to similar to the orbital fractures transfer for diplopia or decreased visual acuity. What about ocular motility? Those patients can have a trapment as well. That would also, I imagine, be a transfer, no?
Yeah, I would say you bring up a good point, and these guidelines are just that. You have to continue to work outside of them. And this is the first, just to get this and published, that people talk about it. And thank you for bringing it up as a subject. But I think that's what happens with the next study, right? Like it took about 15 big studies and other people to modify in their own way to get to a point that people felt good with it. And so I would say this is the first run. We want more physician clinical scientists to help us. But yeah, absolutely. I would say that the other thing here that's important is I think once you get zygomaxillary, like 2 system levels, that to me is always a high impact injury. And we did the same thing for big. If you had 2 types of bleeds, I think that just represents a different type of patient and something to think about.
And you did specify the really complex naso-orbital-ethmoid fractures. Those get transferred. That's a high mechanism injury right there.
Because those are being repaired, I think that's really what it is. And again, remember, this is a subset of our institution of 511 patients. We're basically, the next thing that needs to happen is this needs to be implemented across 7, 10, kind of like we did big, 7, 10 institutions, get 1,000, 2,000 patients and make sure that it levels out. But I think from a high level, when we make these initially, like the first iteration of this needs to be safe, because if you mess it up with one patient, it's all done. It'll shut the whole thing down. And so we are very careful in the first iteration of our guidelines always when we think about this.
I love to hear that, because it means people can feel really comfortable. It might mean they transfer a few that don't need it, but that's much better than not transferring one that does. All right, let's go to Lefort. So type 1 doesn't need transfer. Type 2 and 3 does. Anything else on that?
No, it's straightforward, I think, and with the complexity of these, and it's always fun. It's a good teaching point, but I think this is straightforward. There's not much here.
Now we get to the lower facial bone fractures. So maxillary, alveolar, and hard palate fractures. do not transfer. Now, what if the patient has like a significant malocclusion? You specifically stated that's still okay, but that's not going to be that much fun for that patient. What's your feelings on, if they could get into a OMFS the next day, yeah, no problem. But tell me a little bit more about that.
That's what I was going to say to you. Maybe I think it goes back to how comfortable the system that's about the discharge that patient is. Even stuff as far as diet, nutrition, you start thinking beyond this. Do you have the ability to help this? Or could we get into a model? And again, this sets up a model where we could actually have subspecialists just call in and say, okay, you're going to see me in clinic, like you said, in 24, 48, 72 hours. These are the reasons you come back to the ED. This is how you have to eat. And I think some of that has been great. Our subspecialists here have been phenomenal. And we can write up protocols for them and take them. That's the other thing that people forget about these. This is relationships, and it helps just frame the communications. And so a lot of times we'll be like, okay, look, talk to us. What are you worried about? And the exact same question. And we'll say, okay, this is the situation. These are the reasons why. This is what you would say. This is how you tell them to eat. This is what you tell them to follow up. And the option to transfer is always there. That's the easy answer in my mind. And one last thing I want to say about this. At the end of the day, the clinical exam, whether it be vision, whether it be through the mouth, whether it be any part of the body, the bleeding, the hemorrhage, it's always the clinical entity that leads the patient. I think it's so important for the young listeners out there. Don't ever forget that. It is a key, most important thing that will guide all your decisions that is best for that patient.
I love it. All right. Okay. Mandibular fractures. So if they're bilateral or they're condylar, they come. Otherwise, unilateral mandible away from the condyle could stay.
Yeah. That's the other thing. I think, again, we're getting into the question of physical, like pain, ability to chew, all those other things. But yeah, I think what they represent when you say the bilateral is really what you're talking about here is a high mechanism versus a mechanism that may not have. And I think when you get that the bilateral or condyle fracture, you're now into a different mechanism for the same injury. And that's what would lead it.
Yeah. And chances are they're going to get wired if they're condylar or go to the OR. All right. Soft tissue injuries. Now you have here, and this actually would maybe have me, I work at the level 1, so I'm taking these. I'm just thinking through as a rural listener. Transfer if there's greater than 2 centimeters of missing tissue, which I like. Flap defects. We get these forehead flaps all the time. We haven't seen transfers in these. Do your plastics guys actually want these? They feel the flap dies unless they do something?
No, I think, again, we're just trying to be safe up front. The facial guidelines represents, when we go back to the cosmesis, when you talk about flap and making sure it's healed appropriately, and the person has to look at this the rest of their life. That's the truth. A lot of these injuries happen in young adults. They're not happening in older adults. And so I think that's where that comes from. But that was the nidus behind that.
That makes sense. And then in addition, if they have neurologic signs or symptoms, eyelid or globe lacerations, those also come. And those neurosigns would be things like loss of sensation, paresthesias, or facial muscle weakness. So it would make just the most sense for this to be endorsed, taken whole cloth by either East or West or AAST. What's the plans for this? Is there something already in the works?
Yeah, what you also learn is anytime you're thinking about something, there are about 10 other groups probably thinking about the same thing. The Eastern Association for the Surgery of Trauma has a guidelines committee that's actually working on bringing together all the data and working on putting a guidelines assessment forward. When we went to the AAST and did a multi-institutional trial, that'll be our next goal as our own institution, is really to take this and go out and get partner hospitals and do an observational study where we just say, we're going to follow this guideline. What happens to these patients? Follow them through, get 1,000, 1,500 patients, and then go from there at different institutions with different mindsets.
Love it. All right. I'm putting you on the spot here, but think back to your career seeing bad facial trauma. We're not talking about these low-risk transfers here. We're talking about the bad stuff. Any tips, ideas, things you think people are missing, not doing well on facial trauma in general?
I think remember with facial trauma, it's a lot of blunt force, is the hearing. I think that's another area. I had a machete one year to the face and it went all the way down to the ear canal. And The guy ended up losing his hearing as well. And we don't usually, when you see blood, you're focused on that, and you're focused on repair and bones and plating, and you never think about the auditory side of facial trauma. And I would say that would be the piece that people should not ignore and pay a little more attention to up front.
I love it. All right, I'm going to ask you a hard one you're going to hate. Which patient with facial trauma do you start worrying about blunt cerebral vascular injury on?
That's a hard one.
Yeah, it sucks.
I think when you think about the bilateral mandible, Lafort's 2 and 3, that's what the guidelines would tell us, right? Like whether Colorado or the Memphis guidelines, whatever you use. BCVI, it's such a mysterious, low level incident disease process. Like only when you look for it do you see it. And we're learning a lot about it. But I would say high mechanism by history, bilateral mandibular, and the Lafort's for sure, because it's that sudden stop that causes that deceleration. Those are the ones I would say that I would worry about getting the CTA on.
What should I have asked you that I haven't yet?
I feel like I'm being tested right now. We need to work together to break this paradigm. And I think that you didn't ask me about cost, for example. What is an average one? In our study, mean charges were about, for the patient's discharge, were about $40,000 before, without the transfers, like a helicopter or an ambulance. This is what we're talking about. The financial impact of this on people and their lives and their families is real. And I think you can't just dismiss because we're being safe and protecting our license from being litigated. And I think we have to start being a little bit smarter about all of this. And that's the other piece I would say.
All right. I love it. I can't thank you enough for coming on. Like I say, we got to get you back. We got to talk big. And thank you so much for your time.
Yeah, thanks, Scott. And thanks for doing all the great work that you do. I just want to put a plug in for you and the podcast. You've revolutionized resuscitation and you've made it meaningful. And it's a joy to be part of your work as well. And thank you very much.